They also had the instruments to reduce the bulk of the baby when the baby was dead. Next slide, please. And now we come to the Chamberlain family. Why is this Chamberlain family so interesting and important in our discussion? We go back to France, and in the 16th century, around about 1560 onwards, there was this family of midwives, obstetricians, who would be called for difficult labors. And they would go to the place of the mother where she was laboring and deliver the patient off in a specific way, keeping it a secret. And this way, it went on for generations and generations of the family of Chamberlain. In those days, medical advances or inventions were kept as family secrets because they felt it was their belonging. Nowadays, the moment we have any discovery, we give it out and we let the whole world use it. Now, there was a war, religious war in France, somewhere in the 16th, 17th century, when the Huguenots and the Catholics were having a war, and the Huguenots lost and they left from the coast of France, and many of them crossed the channel and went to England. And the Chamberlain family, likewise, as seen in this cartoon, they got into their family boat, and the guy who's standing up with a little Frenchy beard and his wife Genevieve is Dr. Peter Chamberlain, who was the mainstay of the family, and he made the instrument which he had most popular. And when he landed in England, he maintained his secret practice. So he used to be called by the noble, the royalty. I believe he even delivered Prince Leopold of Queen Victoria. He was called by the royalty also, and he was to go and do the deliveries. And there were many generations of these till in the 18th century, it came to an end. Now, how did they maintain this secret for so many years and years? Well, they had a technique. They would be called and they would come in a carriage of special design, carved from the outside, go up to the residence or the place where the woman was in labor, stop it outside, get off, and an attendant would carry a special carved wooden box which was locked and take that box along with the doctor to the room. Then he would request everyone to leave the room. Then he would even blindfold the mother who was in labor. Then he would open the box, take out the instrument, examine the patient, apply the forceps, remove the baby, wash the instrument, put it back in the box, close the box, locks the box, give it to the assistant, and then unblindfold the woman and call the people inside. This was the system which they followed for years and years, till the last Chamberlain stopped his practice, and the house they were staying in Essex in England, called the Mortimer House, was given to somebody else on sale. And the lady who was staying in the house there, after many years, was rummaging in the attic, and she was cleaning up the attic, and suddenly she saw on the ground a wooden kind of a plug. So she looked around and she saw there was a hole where the plug had come out from. And so suddenly she saw that there was one more plug and one more. So she removed the 4 plugs and she opened a kind of a floor, had a door. And in that place, there was a wooden box which she opened up. Next slide, please. This is the box which she found in the attic of the repository of the Mortimer House. And then she had heard of the rumors that in this area, there was a family who had come from France who was staying and doing these deliveries. So she gave it to the local authorities in the medical profession. And they ultimately traced these instruments to be the instruments, the Chamberlain forceps. Next slide, please. And Chamberlain, this is Chamberlain's treatise on her midwifery practice and showing that their forceps. Now, if you can see this forceps, it's a beautiful forceps with a cephalic curve, but there's a leather strap around it. All that they did was remove the screw from the middle. So both the branches of the forceps could be separated. You apply one on the left side, apply one on the right side, then tie the tape around and then give traction. By dislodging the two branches of a crossed instrument, they could apply it very easily in the pelvis. And this secret they kept with them sacredly for so many years. Next slide, please. This is the cartoon made again by a doctor friend of mine who made the earlier cartoon also, Hemant Morporia, who's a specialist in sonography. And I told him the story and he at once brought out these two cartoons for me. This one shows an old antique bed with a woman who's in labor and the happy Chamberlain who is there inside. You can see the woman is blindfolded. She's covered up with a cloth. There's nobody else in the room. And Dr. Chamberlain is up to his delivery stunts. And he removed the baby off properly. And this is how the secret was kept for years and years and years. Nearly 150, 170 years. Next slide, please. Once the instrument was out, every obstetrician from the major city places where the work was done in UK, in France, in America, in other places, got involved in the design and change. James Young Simpson was a very popular Scottish obstetrician, and he defined that because the babies are obstructed quite high in the pelvis, and because the curve of Caris is J-shaped, you have to have an instrument which can be applied in different ways in the pelvis, and it requires a kind of a pelvic curve. So the instrument doesn't have to be a flat, straight instrument, but if you hold the instrument straight, you can see that this curve which is going up from here is called the pelvic curve. That helps to apply the instrument higher in the position you want, whichever position you think is ideal. Rotate the head as you bring it down and then bring it out in the right dimensions. So he gave the pelvic curve to the forceps, and the Simpson's long forceps was a very common instrument for years together. But then modification never stopped. Next slide, please. He also made, this is the diagram of Simpson showing how he applies the forceps. Here the application is totally wrong because one blade is come on the brow and the other has gone on the mastoid process of the opposite side. It's called the brow mastoid application, and this application is very traumatic for the baby. On the right-hand side, you see that he also tried suction and remove the baby's head out by using a suction aspirator. Next slide, please. Andre Leverett, he was the guy who also gave the assistance, and he also devised the pelvic curve, and he also devised axis traction. He said if you pull on the hand when the head is high up in the pelvis, all it does is abut against the pubic symphysis. So he said you should just apply it in the oblique way, rotate the head round, and apply traction at the biparietal diameter with additions in the fenestrum of the forceps blades or in the shanks or somewhere, so that axis traction is given in the axis where the biparietal diameter of the baby's head is. Next slide. The forceps were classified into four by the disposition of the two branches. This is the crossed forceps, which is the most common design. But in the crossed forceps, when you compress the handles together, there's a compression force which comes on the fetal skull like this. And that is not very good for the baby unless it's a short duration squeeze and the baby is removed quickly. The divergent forceps, which I'll show you, are with a positive force of the pelvic walls and a negative force on the head. So it may extend a little of your episiotomy or perineal tear. The parallel forceps are ideal. They are as if the two branches are not crossing at all, but they come together side by side like this, and are kept together by a special micrometer screw which can approximate them parallelly by a few millimeters if required. Now, in this case, the compression force is constant, and it's not increased as you pull, because the screw will keep both the branches separate in the same distance, and only the traction which you give will give a little compression force to the skull. So the parallel forceps are good, and the conversion forceps are not done because they increase the compression force. So the cross were the old words. Divergent, only very few came because they would cause problems on the pelvic soft tissues. And the parallel is the one which are more new and more common. Next slide, please. This is the divergent forceps of Loff. Dr. Loff was my professor. I studied under him in Pittsburgh, Pennsylvania. He had called me for a fellowship to the Johns Hopkins Hospital, to his university in Pittsburgh, to work with him in fertility management. And we also had great discussions on the forceps which he had designed, because this divergent forceps are very good. All you got to do is put two fingers in the finger rests over there and pull. So if anything, the forceps would open up. But the pelvic walls kept them snug inside, and with little amount of force on the pelvic walls, but zero force or negative force in the fetal skull, the baby was delivered. So it was a good forceps. Next slide. This is Dr. Loff himself, who was a very, very kind and generous man, and he was a very good boss to have in America and an authority in the obstetric forceps. He's written a monogram on the obstetric forceps, which is my treasure, because I've read it, I think, 150 times or more. Next slide, please. Now, Keeland made a forceps which was a single forceps for rotation and for extraction. Now, these kind of rotation forceps, which are higher up in the pelvis, are most avoided in today's practice. You can see the forceps in the right figure, the lower figure. The forceps is applied with the cephalic curve facing the symphysis pubis, and then you would turn it round to apply it on the head, and that would probably make a cut in the lower segment, and incidentally probably may even tear the lower segment. And they were traumatic instruments. I not got them today to show because they're not very used nowadays. Next slide, please. This is showing the application of the forceps in the transverse diameter of the baby's head, in the mid-pelvis higher up. Next slide, keep going on. And as it descends down, the operator turns the baby's occiput in the front and then delivers the baby out by rotation and by traction with the Keeland's forceps. Next slide, please. Here it shows the rotation anteriorly. Keep on going. Very good. Now it's come down to the outlet, and now it will be extracted out with the occiput anteriorly to the side. Now, Edmund Brown Piper, he devised the forceps for the aftercoming head in the breech, saying that the breech delivery, when the head is delivered out, it should be delivered by flexion, because normally otherwise it tends to get extended in the pelvis as you pull on the baby's jaw. The traction should not be given, but traction should be given to the head with an application underneath the baby's body. So as the baby's body comes out in the breech, you hold the baby's body in a towel horizontally. If you lift it higher than the horizontal, the atlanto-occipital joint will get affected and it may cause problem to the baby. So baby is held on the horizontal with a towel, and the obstetrician kneels down, goes underneath the baby's body and applies the two blades, one on the right side, one on the left side, and then gently gives traction to keep it flexed, and the head is delivered by flexion. No one does these maneuvers nowadays. Breech is a safer way for delivering by cesarean section. Next slide, please. This shows you the application of the Piper's forceps underneath the baby's body on the two sides of the baby's head, and then you flex the baby's head gently, and in 1 or 2 or 3 contractions, you remove the baby gently out. To keep showing the next few slides. Little low, applying the one blade on the one side, second blade on the other side. Next, please. Now we come to the forceps at cesarean section. Why should we use a forceps at cesarean section when everything is opened for you? Well, the uterus, which we cut in the lower segment as seen here, has a breadth and we cannot make it extended more than a certain level. Sometimes the baby is larger, but if you are forgetting when you make the cut for the size of the baby's head, that your hand is going to go in the cut and elevate the baby out transversely or with the occiput anteriorly, and that makes the dimension of the cut larger. So, if you turn the baby's mouth in the front, where it is still in the uterus, apply one forceps blade on one side, the other forceps blade on the other side. And gently you first extend the head gently, get the chin out of the incision, and then you push the handle up to get the occiput out of the incision. It is less space occupying and less dramatic if done well at the cesarean section. So people who are used to this do it more often and they're happy with it. This shows you the classification of forceps delivery, which is more theoretical. Next slide, please. So are there any current indications for forceps? There is no place for a purely prophylactic instrumental forceps delivery. You just can't do it to prevent injury to the mother's perineum or anything of that sort, because the 1-2s of the vacuum delivery takes over then because it occupies less space and the head rotates by itself in those situations. The standard indication for expediting delivery for maternal and fetal well-being has stood the test of time, and the indication influences choice of the instrument only in terms of avoiding the 1-2s in preterm gestations. In preterm gestations, the baby's head is very soft. The skull bones are not ossified even at the base. So there, if you apply the 1-2s, it is like squeezing the scalp inside the vacuum cup to cause the suction and to cause the chignon, what we call, and that makes the scalp squeeze the skull bones extra, and that may cause an intracerebral bleeding, and that is dangerous. So therefore, vacuum is not indicated in premature labors where the forceps can be more in a cage effect, preventing the compression of the baby's head. Otherwise, the vacuums cause over the forceps. Next slide, please. Indications are quite standard. Prophylactic forceps, the concept produced by Joseph Dilly, is not practiced. It was done to only minimize the exertion of the patient in certain situations. And if the second stage was prolonged, to cut short the second stage, maternal exhaustion, abnormal fetal status with fetal distress, and in special situations of a rotation, which is also not done nowadays. Next slide, please. Now, the trial of forceps is what, when you examine the patient, you feel that there is a little tight fit, but with a forceps and little amount of rotation, the baby can come out easily and safely in 1 or 2 contractions when you assist the contraction with the forceps. In those situations, it is useful, especially in the case of anesthesia in the operation theatre. Next slide, please. Contraindication to these forceps would be a definite cephalopelvic disproportion where the baby's head is larger than the pelvic diameters. Number 2, fetal malpresentations where larger diameters come into play in the pelvis. Number 3, high station of the presenting part. You can never apply forceps high in the pelvis nowadays. Cervix is not fully dilated, a complete contraindication to the forceps. And fetal disorders. Next slide, please. So for doing the forceps, head should be low at the outlet. The occiput should be in the front as far as possible and not high. Next slide. This is just telling how to prepare the mother. Next slide, please. Now, this is a parallel forceps delivery shown to you. Primary post-dated induced with prostaglandins. She had got epidural analgesia, which puts the patient into rest. No pain, no pushing. If she doesn't push, then you have to do some amount of pulling to remove the baby out, where a ventouse could be used more successfully for the auto rotation and the delivery. Or like you're seeing here, apply a forceps here, the left forceps branch first inside on the left side of the pelvis after lubricating it. There goes. Then the right forceps branch on the right side of the pelvis. You get both the blades near one another and you put the micrometer screw and you adjust the parallel forceps so that the force on the biparietal is as adequate and not more. And then with the subsequent pain, you pull and you extract the baby out by increasing the height of the contraction. All you got to do is mimic the contraction, and here in this case, it's a face to pubis delivery. You can see that he's giving traction, and there you can see the baby's head coming out first, the occiput, and then in the which is posterior, and the face which comes afterwards by extension, which is anterior. This is a face to pubis delivery with the application of a parallel forceps designed after Wallace Shute from Ontario, Canada. This may be allowed in certain situations if the doctor is skilled with a mediolateral episiotomy, and it's a safe way of taking a baby out for child. Please carry on with the presentation. They're showing that the traction was along the curve of Caris, which is the curve of the pelvic cavity. Rotation becomes quite spontaneous, and in the vacuum, it is an auto rotation which takes place. This was the phase 2 pubis delivery, which is not very uncommon also when you're delivering a baby. The occiput goes snugly at the back in the sacral hollow, and the face comes under the pubic symphysis. Now, forceps in vacuum, there's no actual, vacuum is definitely safer for the baby, except, like I told you, for premature babies, where you prefer to have a forceps for a cage effect, but the vacuum will be hazardous. Next slide, please. But this is an instrument required. This is only for, next slide, please, postgraduates. So has the requiem for instrumental deliveries already been sung? Have you already sung the last song for the forceps? Maternal perception of fetal injury, they say no for the forceps. Fear of medico-legal problems for the doctor, they also are cautious with the forceps. And the increasing safety of cesarean deliveries nowadays. So much so that cesarean section deliveries are slightly done a bit too often and for not a real indication. And that should not take place. You should do well-indicated cesarean sections when is indicated and not refrain from doing one when it is indicated. Next slide, please. The epidural analgesia is becoming more and more common in labor as women want to have painless labors. It's a good technique to give for painless labor, but the woman doesn't feel any second stage contractions. And therefore, the duration of the second stage becomes prolonged because she does not push. And here, instrumental delivery is increasingly employed to shorten this. All you got to do is apply the vacuum cup, and when she gets a contraction which is going up and down, you have to mimic the contraction by pulling a little as the contraction becomes higher. And as it goes to a peak, you give a maximal traction. And as it goes down, you don't relax your hold, keep the baby there, and let the contraction go. Then you don't do any traction. You wait for the next contraction. Let the contraction again come. Give a little traction. Then as it goes to a peak, give a little extra traction. Hold it there, let the contraction go. So contraction by contraction, you get a little amount of descent and rotation. And this, especially a vacuum, can be used to assist the patient You cannot push after getting an epidural anesthesia. This is a common thing done nowadays. Next slide, please. Training is done by mannequins and other gadgets which we have in the labor rooms of hospitals. And that supervision of experienced obstetrician is required whilst doing the training and whilst doing the earlier cases of instrumental deliveries also. Next slide, please. So we conclude with this Latin saying, non vi sed arte, not with force, but with skill. You must think there's this instrument. It's not made of stainless steel, but it's made of plastic or glass. Then you'll apply the least amount of pressure, least amount of strain, and use just two fingers for probably delivering or extracting the baby out and causing no injury. Thank you, folks. I hope I've done a good job in telling you what the place of vaginal delivery is nowadays. If any questions are there, they are welcome. Thank you. Thank you, Raju.
Excellent.